Welcome to ATCM, the Emergency Medicine channel. Today I will be presenting a dengue fever case. Can I start, sir? A 61-year-old male patient was brought to a ER with complaints of fever since last 1 week. Initial 10-second assessment, patient was conscious oriented and obeying commands. Primary survey, his airway was patent, there was no pooling of secretion, no gurgling or hoarseness of voice. Breathing, his respiratory rate was 18 per minute with a saturation of 100% and chest exertions were normal, air entry was bilaterally equal, there was no added sounds. Circulation, his pulse rate was 66 per minute and blood pressure was 150/90 with a MAP of 110. Disability, his GCS was E4, V5, M6 with pupils 2.5 mm reactive. And exposure, temperature was 98 degree Fahrenheit and GRBS was 128. So as a part of adjuncts to primary survey.
Exposure, any rashes?
No sir. There is no life-threatening features in the primary survey, so I proceeded with the sample history, sir. Signs and symptoms, he had fever with chills and rigors since the last 7 days, which was initially treated symptomatically. He had associated severe headache and occasional dry cough, and after 4 or 5 days he started having recurrent episodes of vomiting, and with that he was taken to outside hospital for that, but there was no seizures, altered sensorium or any bleeding manifestations like hematuria, hematemesis, blood in stools, petechia or ecchymosis or altered sensorium. Then there is no history of any allergies. Past history is a diabetic and he is having CKD. Stage is not known, but not on dialysis. He is having good urine output according to history. Medications, he is on hydralazine, cilnidipine, Ditor, Metalar, Glimepiride, Teneligliptin and Mixtard. Last meal was taken 2 hours back. Events with this complaints, he was taken to outside hospital and he was admitted there on the 4th day. That time they did a dengue NS1 which came to be positive. Then after that, in the hospital stay, his fever subsided on 5th and 6th day, and but there was gradual drop in platelet from 60,000 to 35,000 and to 20,000.
Oh, here is a gentleman who had presented with fever with chills and rigor, right? Diabetic. What are the differentials you are going to consider other than dengue?
Urinary tract infection, pneumonia.
Pneumonia.
Fever with chills and rigor.
Pneumonia, any respiratory symptoms at this moment?
No, he
so pneumonia is out. Or you can tell atypical pneumonia, that is one thing. Now at this time, COVID will be the first differential at this point of time. So COVID, any viral illness to be the first one, followed by your fever with chills and rigor, urinary tract infection. It's a known CKD patient, so chance of getting infections are high. Then
malaria,
okay. So any travel history?
No sir.
Travel history. Is it required to have a travel history?
No sir.
Ideally in Kerala, how frequent is the incidence of malaria?
It is very rare, sir.
It was rare, but now the thing is that there are a lot of migrant labor workers have come, and even there are case reports where without any travel history, patient has become positive. So that is one thing. The positive can happen, but the incidence is not very high as compared to other states. That's one thing. So malaria, what is transfusion malaria? Transfusion related malaria. Again, after blood transfusion, the patient can have malaria infection. So that is one of the rarest of the entity. I think it is Vivax or falciparum. I'm not very sure. So that is one thing. So always consider malaria with fever with chills and rigor. Malaria is one of the differential. Any other GI symptoms?
Only vomiting was there.
So what could be the other DD for you?
Vomiting days.
Fever with chills and rigor, vomiting, maybe he is taking food from outside.
Gastroenteritis.
Enteritis as such, it is not there.
Acute gastritis.
PU, one of the commonest finding of PU is typhoid. So always consider 1 week history of evaluation, who is having fever with chills and rigor. So these are the common differential. Again, leptospirosis, again one of the commonest differential, maybe CKD, worsening of creatinine, thrombocytopenia, fever, all those things. That is a history. Anyway, here it is straightforward. They have done a dengue NS1 and it has found to be positive. Now at this point, what are the different diagnostics available for dengue? Diagnostic test, and when you should order for each one of this. Such patient coming to your emergency room. For example, somebody has come with 2 days history of fever.
Yes, sir.
Into you, in front of you. So what test you will ask for?
Initially, first 1 to 3 days, sir, dengue NS1 antigen will be positive. Then after that, from 3 days to 6 days, usually the IgM will be positive.
Okay.
Then after 1 week onwards, IgG is positive.
Okay. Suppose this patient has come. Okay. His NS1 as well as IgG is positive.
Yes, sir.
What does that mean?
That means he is having a dengue fever at present, and he previously had a dengue infection.
So he had a secondary dengue infection. So such dengue infections can become serious at this point of time.
Yes,
So they can have, because lot of patients we are seeing with secondary dengue these days. So they can have recurrent infection with dengue, and they can have second time it can be serious. So that is the one thing.
Could be different strain also.
Different strain also. So that is one investigation. So you have to be very clear in ordering your investigation. Somebody is coming with 1 week history, don't ask for NS1. You should straight away ask for an IgM. After somebody is coming within 3 days, you should not ask for an IgM. You should ask for an NS1. So that is the investigation that you need to be aware of.
What is the non-invasive test which WHO recommends in low-income countries?
Regarding
Clinical test.
thrombocytopenia.
What is tourniquet test?
Hess test can be done, sir. That means BP cuff is inflated between systolic BP and diastolic BP for 10 minutes. 5 to 10 minutes, and after that we should check for the peticase. If there are more than 10 peticase in a 2.5 centimeter area, that means it is positive thrombocytopenia.
So that is one investigation. So again, you have to be asking this investigation again for any of this investigation. Whenever you are asking IgM, the fever history has to be there for 1 week. Only after 1 week, when you ask for lepto, whichever IgM test, after 1 week only you ask for an IgM test.
Yes,
so IgM, IgG and NS1, you should know how to read these investigations. Okay, now continue. What has happened to him? His platelet was dropped and he was referred here.
Head to toe examination. In the head, in the central nervous system, higher mental functions were normal, sir. Ideally, we have to look for the fundus for retinal hemorrhages also. There was no gum bleed or oral bleeds, no lymphadenopathy or no neck stiffness. Central nervous system examination, everything was normal, sir, including the cranial nerves and sensory and motor system. Then there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema, and there was no petechia or purpuric rashes. And joints were examined. There was no joint swellings also. Then in the chest examination, inspection, trachea appeared central and chest excursions were normal, bilateral air entry appeared normal, breath sounds were also bilaterally equal, there was no added sounds, and cardiovascular system examination, both heart sounds were normal. Abdomen examination, abdomen inspection, abdomen was distended, there was no guarding rigidity, and bowel sounds were present, no organomegaly was palpated. So in this patient, we came to an impression of dengue fever with one warning sign, that is vomiting.
Okay. So now let's start discussing from the patient coming to the emergency room. Okay, this same patient has come to the emergency room. So now you have decided that he should admit the patient, where to admit, and next thing, what all investigations you need to send, can we send him home? So you can just elaborate on these points.
There are different phases in case of dengue fever. So initially it will be a febrile phase. That means a patient will be having fever, that is called the breakbone fever, because they will be having myalgia, arthralgia and severe headache, that is retroorbital pain will be there, and body pain will be there, and sometimes patient might be having vomiting also, and in some patients they will be having upper respiratory features also. Then coming to the next stage, that is the critical phase. There what is having a patient, what is happening is the body will start responding to that. So there will be an antibody antigen complex will be formed, that will go and bind to the platelet, then thrombocytopenia can occur. Then there can be a vascular leak also. That is
a phase where it will go to the dengue hemorrhagic shock.
So patient can go for bleeding manifestations can be there and hypotension can be there. That will be usually coming after 3 days. Then after that will be the convalescent phase. Patient will be improving. So if at all a patient comes in a later stage, like after 4 to 5 days with a platelet which is between which is anyway more than 1.5 lakh and all, and they don't have any symptoms and their symptoms are resolving and all, we can plan him on admitting to the ward, or if the patient's house is nearby, we can monitor his platelet count and can be discharged home. Patient should be admitted if there are some warning signs like vomiting, like BP is in a borderline, or the platelet counts are dropping. And ICU admission is required if the patient's blood pressure is less than 90/60, with the hematocrit of more than 50 and platelet count less than 10 with bleeding manifestations or altered sensorium.
Platelet count less than? ICU admission?
50.
See, ICU admission criteria as such, you can call it as like 10,000, definitely less than 10,000, there is a high chance of spontaneous bleeding. So that is the point when we decide for transfusion. Okay, so, so that is the thing that we have to do. Next, what are the management aspects?
Yes, sir. Management aspect, mainly it is depending on the patient we have to manage. Mainly it is supporting management.
Investigations, what all things you need to send?
Investigations.
Other than our NS1, all those tests, what all investigation? In this patient, you can have a stable dengue. This patient, his platelet is dropping. He might need an ICU admission. He also having an underlying CKD also. So for this patient, what all investigations you will ask for specifically?
First we should look the CBC. So this patient CBC was 5 total count was 7,000 with a platelet of 17,000. So we need to look the manual platelet counting. So peripheral blood smear was sent and it was showing a manual platelet of 20,000 only.
20,000, okay.
Then hemoglobin was 12.9, sir.
12.9, okay. What is hematocrit?
Hematocrit was 34.9.
34.9, okay.
So CKD patients are more prone for associated other infections also. So his CRP was 35, but procalcitonin was little bit high. Usually in viral fever, procalcitonin will be negative. So this patient 5.83 was there.
Okay. Because of the renal failure also.
Then RFTs were checked, sir. Urea was 114 with a creat of 3.92.
3.92, 4 creatine and 120 approximately. So the ratio?
13.58 is the 1 creat ratio. And his baseline creat is also around 3. Sir.
So it looks like an intrinsic renal failure rather than pre-renal intrinsic renal failure. Okay.
Then liver function test should be done, sir. Usually in viral infection there can be a transaminases. So bilirubin was 0.4 with a direct bilirubin of 0.21 and SGOT, SGPT was 97 and 44. Slightly on the...
Can you get SGOT, SGPT in thousands in dengue?
Unlikely, but rarely. In severe dengue infection it can come, sir.
Previously, like 2 years down the line and all, when the strain changes usually, when we have sudden dengue deaths, whenever the dengue deaths will happen is that suddenly the strain will change, mutant strain will come. Maybe 2 years back we had a lot of cases who had been coming with a lot of SGOT, SGPT hepatitis more than 1,000, 2,000 and all. So we can't assure, whenever we say above 1,000 we will say it is toxins or ischemic hepatitis. These are the usual things that we used to say. But dengue also you keep in mind, also viral hepatitis. Dengue also you keep in mind that it can have 2,000, 3,000 like that of a picture, but rarely. But now the last 2 years after that we are not seeing to that extent, maybe like triple or 4 times rise of SGOT, SGPT, and the disease decreases. The SGOT, SGPT usually within 2 weeks time it comes back to normal. So that was the trend. Any other investigations?
We even had some co-infections also.
Co-infections.
Dengue with hepatitis.
Then since this patient presented after 1 week, we have to send IgG and IgM, sir.
Importance of albumin, sir?
Albumin, since he's having chronic CKD and all, albumin is 2.9 for this patient. Usually in acute...
This is one scenario where we can go for a liberal albumin for volume resuscitation also. Make a lot of physiological sense.
Then ferritin was censored. Ferritin was 3,896.
Routine cases you want to send ferritin. What is the indication of sending a ferritin here? It's a acute phase reactant, so it will increase.
Increase only.
So what was in your mind when you are asking for ferritin?
We have to look for associated macrophage activation syndrome or HLH features, whether it is there or not. We have.
So how frequent you can see HLH with dengue?
It is often seen, sir.
Now, as you said, whenever the mutant strains come, so that is a phase where, like 2 years back, we had a lot of dengue-related macrophage activation syndrome, and after that phase, since last year, it is significantly declining. We had seen maybe many number of dengue cases, but hardly any of them have gone for macrophage activation syndrome. And but whenever, like maybe next year, down that after 2 years, we can expect this to happen. So always keep in mind, macrophage activation syndrome can be one of the possibility. So how will you diagnose it, macrophage activation syndrome?
So we should suspect when the patient is having bicytopenia with the splenomegaly with fever, and patient will be having high ferritin and fibrinogen values. Triglyceride will be more than 300.
So that is the one consideration that you need to give, and that is the time when you have to think of giving steroids, or depending upon cytosorb therapy, all those things you can consider during that time. Okay.
Yes, sir.
So these are the investigation that you have asked
and
for.
Ultrasound abdomen also, sir.
Ultrasound abdomen. Reason for an ultrasound abdomen in a dengue.
Usually we do ultrasound abdomen just to look for other warning signs, like if there is some ascites because of the vascular leak, ascites or pleural effusion can be checked. Then in HLH we are suspecting splenomegaly also will be there.
Okay. He has CKD.
Yeah.
You have to look for the kidney size, CMD differentiation and all. Then also how frequent it is pancreatitis and dengue. It is not very common, but it is very common with leptospirosis. Yes, so as we say, any viral infection can cause pancreatitis also. But dengue pancreatitis is not very common, but it is very common with leptospirosis, yes, which has got similar clinical picture, similar fever with thrombocytopenia with renal failure. That is the only difference. Then ultrasound here, SGOT, SGPT was mildly altered. We are not going to gain anything much on that. Fine. Then? Investigation. Then treatment part?
Treatment part, we have to approach the patient from airway, breathing, circulation. At present, in the ABCD, there is no active interventions required, sir. We should avoid arterial punctures for this patient. Then
IM injections.
IM injections. And there should be strict blood pressure and input-output charting for this patient, and watch for the warning signs like seizures, altered sensorium, reduced vision or other bleeding manifestations. So this patient platelet count is 17,000. So whenever the so at present we are not planning to transfuse, but whenever the platelet count is less than 20,000 and all, and if there are bleeding manifestation, we should transfuse platelets.
Okay. Suppose the platelet count is like 10,000 and he don't have any bleeding manifestations. So what will be your plan?
Monitoring platelets.
Okay, less than 10,000, definitely yes, you need to transfuse. How will you do platelet transfusion?
Platelet transfusion criteria, sir?
No, how will you do means how much you will ask for. Yeah. So less than 10,000 you have asked for a platelet count. So how will you give platelet? You have different modes of available platelets. Yeah, can you elaborate on that?
We have single donor platelets, sir. We have pooled platelets and single unit platelets are also there. So whatever platelet we are transfusing, the platelet half-life in the transfused platelet will only last for 24 hours. So if we are giving a single donor platelet, it can increase a maximum platelet count up to 50,000 only, and if we are giving random platelets, it can increase up to 10,000 to 20,000, sir.
Okay. So which thrombocytopenia we will not be transfusing platelets?
In TTP and ITP we will not be transfusing.
TTP, it is definitely contraindicated. ITP,
in severe
ITP less than 5,000 or any minimum manifestation only we will be transfusing.
Or if we are planning for surgeries or procedures.
So any other drugs that you need to start in here?
Mainly conservative management and fluids is a management.
Hydration is the key here. Okay. Hydration is the key, and always remember that you should be avoiding drugs that cause thrombocytopenia. Like all your NSAIDs should be avoided. Pantoprazole to some extent, because pantoprazole is One of the side effect is that it can cause decrease in platelet. So you have to be checking the platelet count and possibly avoid pantoprazole. But routinely it is not needed. You can give like H2 blockers, but it is also prone to develop thrombocytopenia. Then any other role of any antibiotics?
In this patient, procalcitonin was slightly on the higher side, so
Okay.
there can be an associated infection.
So where will you think of any infection here?
He was not catheterized and all, so
Only thing that he was in a hospital for few days. So you can
Hospital
consider
acute-
a hospital
hospital
acute
acute
infection. So right now you don't have any other symptoms. Maybe only the source may be urine. That will be the only source of infection is prostatomegaly. Anything is there in the ultrasound that might suggest after your urine routine examination. So what antibiotic you will start at this point?
doxycycline, sir, there is gram positive, gram negative coverage for doxycycline.
Okay. Doxycycline is a good coverage. It has got urinary coverage also. So doxycycline is a reasonable antibiotic to start with. Then
Otherwise, ceftriaxone can also be.
ceftriaxone also can be tried. Penicillin.
That will be having usually gram positive only.
More
so
of
gram
gram
negative
positive.
also is.
Gram negative will not be there. Augmentin is also a fair choice. But whenever you have a fever with we are suspecting a viral fever, better avoid augmentin or penicillins. Why?
IMN and all, it is chondritic.
So when you are glandular fever, especially, it is a common OPD practice to send away with augmentin, and they will come back with rashes. So those things should be avoided. Okay. So he was in the ICU. He was admitted to the ICU. He had never had any bleeding manifestation. Any role for L thrombopac? In dengue?
Thrombopac, usually we will be giving in dengue, I don't think.
Dengue, there is no definitive role, but the proven role is in, I think it's in hepatitis C related thrombocytopenia. Definitely, there's an L thrombopac has got a role, and in some role in ITP also. That is the only area where it has been shown benefits.
Usually, L thrombopac and romiplostim, both things can be given to increase the protection of the
platelet. But in dengue, definitely no. So, anything else?
What is carica? Papaya? What's the word carical?
It is told that the papaya leaves can increase the platelet counts. So usually
That's a pharmacological preparation called caripel.
Caripel,
It's being used
yes.
very commonly in South India. There are some papers supporting the evidence also, mostly in moderate disease. Okay. Then what are the platelet transfusion threshold? You told about 10, but is there any scenario where you're going to transfuse at a higher threshold?
yes, sir, if we are planning for some minor some procedures like central line insertion, artery line insertion and all, we should keep at least a 20,000 platelet count. So for that we can transfuse, and if we are planning for some minor surgeries, we should keep the platelet more than 50,000, and neurosurgical procedures more than 1 lakh.
Anything else, Suresh? Okay. Fine. Okay. How is the patient now?
Patient improved symptomatically without any transfusions. So gradually his platelet counts were improving, and today it's 2 lakhs. So we are planning to discharge.
So the key is that once the platelets start increasing, there is no need to monitor further. It will automatically come back to normal. And at the time of review, he might have thrombocytosis. That is the usual.
Vaccines.
Okay.
What's the role of vaccine?
Or dengue vaccine. Any vaccine available to prevent dengue?
Dengue vaccine is there, which will act against the dengue V1, V2, V3 and V4.
Okay.
And some other vaccines are also available. Yes, sir.
Okay. Fine.